So I'm here to speak to you about the work that my colleagues and I have been doing really over the past 20 years with Hispanic families. And along the way, we have had some successes. We had also, have some lessons learned in areas where we didn't do as well. And we really did learn a lot from those lessons and really use them to capitalize on opportunities and to really, in some ways, reinvent ourselves and learn from what we have done in the past to do better. And so I'd like to acknowledge all of my colleagues, whether it be my full-time staff, who many of whom have been with me now for 20 years, actually, since we started this work, and to my many Ph.D. students and postdocs in our Life Lab, which stands for Latinx Innovations for Family Empowerment. And with that said, I'll get started. So why am I particularly interested in working with Hispanics and Hispanic youth, particularly here in South Florida? So I myself, I'm a product of Miami and the Miami-Dade County Public School System. And, it was always really my dream, to be able to give back to my local community and to be able to do work actually in the Miami-Dade County Public School System. So at the time, as I was transitioning and exploring PhD program opportunities, I came across Jose Shaposnik's work, whose work was mainly focused on family therapy and on the treatment of drug abuse disorders. And I, with several other colleagues at the Center for Family Studies, were much more interested in prevention. And so, we started really focusing on preventing some of these maladaptive behaviors. And so, our work with Hispanics in the area of prevention really began. Today, we have more than 60 million Hispanics in the US. We are one of the largest and one of the fastest, no longer the fastest growing, but still one of the fastest growing populations in the US. Hispanics compared to non-Hispanic whites, and specifically non-Hispanic white adolescents, report greater substance use, including alcohol use and illicit drug use. Higher rates of overall HIV infections in adults among Hispanics compared to non-Hispanic whites, and higher rates relative to non-Hispanic whites in terms of unprotected sexual behavior. As you see there on the slide, 15% of Hispanic youth experience a major depressive disorder at some point in their lifetime. With respect to unhealthy weight and obesity, and I'm presenting this slide because we have been doing a lot more work in the area of obesity prevention over the past 7 or 8 years. And what has motivated this particular area of our program of research is that, again, Hispanics report higher rates of unhealthy weight compared to non-Hispanic whites and other groups. As you see there on the slide, non-Hispanic Blacks have similar rates to Hispanics. Within the Hispanic population, there's quite a bit of heterogeneity, as many of you know. Certainly, the Hispanic community in South Florida has evolved quite a bit. It used to be that about 75% of our sample was Cuban, and over the years that has evolved now to less than half of our sample is Cuban. Now we have a much larger representation of Central and South Americans. In other parts of the country, there's also quite a bit of heterogeneity, specifically as you look at areas such as New York, with a very large Puerto Rican population, and then thinking of, the West Coast, for example, which the Mexican American population is more prominent. But in addition to country of origin, one of the other things that really distinguishes Hispanics is whether they are US born or foreign born. And more often than not, US born Hispanics are at greater risk for a number of different types of behavioral and emotional disorders that we study, including but not limited to rates of obesity, rates of drug use, rates of cigarette smoking. Greg briefly mentioned that our team does a lot of work with family-based interventions. Really, our hallmark intervention is the Familia Sunitas intervention, and I'll speak much more about it in detail over the coming slides. But briefly, Familia Sunitas is an evidence-based, culturally informed intervention for Hispanic adolescents. We typically work with adolescents 12 to 17 years of age and their family The 12-week intervention is delivered through multi-parent group sessions and through individual family sessions. As you see here, we're in a number of evidence-based registry, including but not limited to Blueprints, the CDC EBI program, and of course, I think that all of us here, most of us know about NREC program and how the prior administration took that down, the NREC program from SAMHSA, and hopefully there'll be some changes to that in the not too distant future. I am preaching to the choir here, and so I won't spend too much on this slide because I'm sure that everyone is very familiar with the socio-ecological model of public health and our extension of this model, which we've termed eco-developmental theory, that basically postulates that adolescent risk is influenced by a number of different systems, from those systems that are most proximal to the adolescent, such as the family microsystem or the family world, also the peer and the school worlds, and the intersections of these microsystems into the family peer meso and family school meso. In addition to that, we also believe that the exosystem and those macrosystemic processes also play an important role in influencing adolescent behavior. So what does the Familia Sunitas intervention target? As I mentioned earlier, we focus really on the microsystemic processes. And really, as you'll see from a table I have in an upcoming slide, looking at the session by session content of the Familia Sunitas intervention, we focus a lot on the family world. So we believe that family risk and protective factors have very powerful effects on adolescent health. In fact, the literature of many individuals at the PRC and elsewhere across the country have shown this not only in cross-sectional, but also in longitudinal studies. So some of these risk and protective processes are ineffective communication between parents and youth, parental involvement in the youth's world, including but not limited to the peer and the school world, positive parenting and positive reinforcement, and general family support and family cohesion. We also spend some time, although less time, focusing on the other two worlds, specifically the peer world and the school world. For example, in the peer world, one of the risk factors that we always focus on is peer pressure, and specifically around using substances or engaging in other maladaptive behaviors. Here's that snapshot of the session by session content. As I mentioned earlier, the intervention consists of 12 sessions. 8 of those sessions are exclusively multi-parent group sessions, where a group of 12 to generally 15 parents participate in a group, and they're empowered through very much a participatory process that's often done by role play, by families chiming in. They learn a number of different skills that are central to parent training programs, skills such as enhancing their communication skills, the importance of parental monitoring of the peer world, parental investment or parental involvement in the adolescent school world, and as I mentioned earlier, also a focus on family support and behavior management. Interspersed across the 12-week intervention period, there are 4 family sessions where it's the individual families participating at a time with a facilitator or coach. And during this family sessions, parents have an opportunity to practice some of the skills that they learned in the prior group sessions with their own adolescents. We really believe and really place an emphasis on the parents are the agents of change in the family. And in fact, our family functioning, and those are the indicators again of communication and behavior management and family support and parental involvement, are the mechanisms of action that we hypothesize drive the effects of our interventions on the different outcomes. And in fact, we have shown that in repeated studies. Briefly, what I hope to go through over the next 40-45 minutes or so, what I have left in this presentation, is really to show you how our work has progressed from pre-intervention studies, really focusing on formative development work that we do to help inform some of our interventions. I'm also planning to highlight the findings of some of our efficacy and effectiveness studies. And then I'm also hoping to speak about, and hopefully I have time to do this, to speak about some of the work that we're doing in implementation, thinking about adoption and feasibility testing, but really now starting to think of larger, bigger picture, thinking about sustainment. And in fact, in our most recently funded NIMH study, sustainment is actually the primary outcome of our study. And so I hope to get to that at the very end of this slide deck. Very briefly, I want to set the stage in terms of some of the initial work that we did with the Familia Sunitas intervention. We did multiple efficacy trials during the early 2000s. I'm only selecting one here to show you the results. It's one where I thought that the results were particularly of interesting to me, and hopefully you find those of interest as well. In this particular study, we were examining the efficacy of our family intervention relative to two attention control conditions that controlled not only for the dosage, but also controlled for the format intervention, for the format of the intervention, Familia Sunitas. So both the HIV Preventative Intervention and the health promotion intervention, they were also parenting training programs. They were also delivered in multi-parent group sessions and individual family sessions. The HIV Preventative Intervention was developed by some colleagues at the time in the New York State, upper state area. And there were some publications in that area by B. Krause and her team. We had four outcomes that we were particularly interested in measuring. And so we collected data on cigarette use, illicit drug use, alcohol use, and unprotected sex over time. We collected data at 5 different points in time for this particular study: at baseline, 6 months post-baseline, which was approximately 3 months post-intervention, then again at 12, 24, and 36 months post-baseline. We hypothesized that we would see improvements in family functioning short-term from pre to post, given that that's, and again, this is parent report of family functioning. We hypothesized that the family-based intervention, Familia Sunitas, and the HIV intervention would do equally better with respect to preventing and reducing unprotected sexual behavior relative to the health promotion intervention, which focus on reducing risk factors for cardiovascular disease, including but not limited to preventing and reducing cigarette use. And because of that, we expected that the Familia Sunitas intervention would do equally as well than the health promotion intervention with respect to preventing and reducing cigarette use, and that they would both do better than the HIV preventive intervention with respect to that particular outcome. In terms of our findings, which were published now almost 15 years ago, I'll get to those in the next slide. But basically, you see a summary here of what I said before. We had 266 families that were assessed at baseline and randomized to one of the 3 arms. And again, we assessed at 6, 12, 24, and 36 months post-baseline. Our participants, we had, as you see, slightly more females than males. As I mentioned earlier, we typically work with Hispanic youth in the age range between 12 to 17. Having said that, most of the youth we work with are early to middle adolescents, and most of our youth are in fact 12 to 15 years of age. And so the mean age in the sample was about 13 and a half. We do, and this has changed a little bit over the years, but typically we have worked with families who reported low family income and were low SES families. In this case, about 60% of the families participating in the study were at or below the poverty line, which back in 2007 was a little over $19,000 for a family of 4. In terms of the percentage of youth that were foreign-born relative to US born, as I mentioned earlier, in our earlier studies, it was about 75% in the 90s, particularly in some of our treatment studies that was conducted at the Center for Family Studies. In the 2000s, that had decreased to about 60% foreign-born, and now what we're seeing is more 2nd and 3rd generation Hispanics, So in our more recent studies, we have somewhere between 30 and 40% of the youth being US born, pardon me. In terms of the findings, I wanted to really just have you pay close attention to two things. One is the figure on the left, which is the changes of family functioning over time. Basically, we saw that the Familia Sunitas intervention had increases in family functioning from baseline to 6 months. They leveled off. We really didn't see any more improvements from 6 to 12 months. And in fact, if we continue to look over time, and if I would have plotted out the 24-month and the 36-month, what you would have seen is continued stability in the intervention arm. In fact, maybe a little bit down at the 36-month post-baseline, but really pretty flat. And we saw continued decreases in the other two intervention arms. With respect to the right-hand side of the slide, and this is the percentage of youth who reported current cigarette use. This is smoking in the past 90 days, and this was more than just a few puffs. What you see, and what was interesting to us, in addition to the fact that cigarette smoking went down, particularly after the 12-month post-baseline assessment in the intervention arm, we saw the significant increases over time in the cardiovascular promotion intervention. And what was really interesting to us in this particular study was that the heart intervention, or the health promotion intervention, as I mentioned earlier, really focused on preventing and reducing cardiovascular risk behaviors, such as cigarette use, by really encouraging parents to talk to their youth about the importance of not engaging in some of these risk behaviors. For example, the importance of not engaging in cigarette use. And so to be candid, we didn't have, I think, a really good explanation when we published this paper back in 2007. And it was until some time later, I can't recall when it was, but it must have been a year or two after that. I was, at home and watching a Philip Morris connection, and I remember a Philip Morris commercial, and I remember the commercial that it was geared towards parents, and the commercial said, parents, talk to your kids about the importance of not smoking. And it made me pause, because I always thought to myself, sort of being, somewhat cynical, why would a big cigarette company tell parents to talk to their kids about not smoking? And, I also thought, well, these companies have a lot more resources than we do, and are oftentimes doing some of these studies well before we are. And perhaps they knew something that we didn't know. And that, in fact, when you encourage a youth to not smoke, particularly when communication is not high and there's quite a bit of ineffective communication within the family, then the intervention would have a completely iatrogenic effect. And in fact, although I'm not reporting the results here, but are published in another paper, when we did some moderation analyses for all of the different outcomes that I reported earlier, unprotected sex, cigarette use, etc., what we found was that the health promotion intervention was iatrogenic when kids reported low family functioning at baseline, and that the PATH, or the HIV intervention, was iatrogenic for those families that reported low communication at baseline. So for those of you who are parents of teenagers, I'm sure you have very effective communication skills, but if you have friends where that doesn't happen, you may want to talk to your friends about the importance of not encouraging their kids not to engage in a certain behavior where their general communication isn't maximum. We then replicated some of the results in an effectiveness study that followed soon after the efficacy study. We worked in collaboration with half of the middle schools in Miami-Dade County, and they implemented our family-based intervention, as I said, in about half the middle schools in the county. They were delivered by the school counselors and the school social workers. We compared the intervention relative to standard of care. In Miami-Dade, at the time, that was sexual health classes that were provided in health education. And for this particular study, we randomized 746 Hispanic youth into one of the two arms, the active intervention arm or the standard of care community control group. We assessed families at 6 months post-baseline, which again coincided with approximately 3 months post-intervention, and also 18 months post-intervention and 30 months post-intervention. As you can see here by the percentages, we tend to do fairly well, I would say, in terms of being able to retain our families over time, particularly with the families that we work with. As you saw earlier, half or more than half of our families are foreign-born. It's a fairly low SES sample, so these families are fairly mobile. So it does take quite a bit of resources to really be able to follow these families up successfully and really keep very good track of where they're at and where they're going, etc. So as I said, we work with, this represents about half the middle schools in Miami-Dade, public middle schools, I should say, in Miami-Dade County. You see there about a 50-50 split between males and females. Average age, we were working with 8th graders, so no surprise that the average age there was just shy of 14. The parents' age was 41, and just as before, we had approximately 50% of our sample was US born. Family income here was a little higher than our prior efficacy study, given that this particular study was really supposed to be a lot more representative of the Hispanic population in Miami-Dade County. And unlike in our efficacy study where we worked only with 2 or 3 schools in the same geographic area to have a very homogeneous sample, with the goal of having a much broader and a much more heterogeneous sample, we were working in areas of Miami-Dade County that were much more affluent. For those of you that are familiar with South Florida, we were also working in neighborhoods such as Coral Gables or Key Biscayne, but also working in significantly less affluent neighborhoods, including Homestead, which is home to our Mexican migrant population. In terms of how did our facilitators do, and again, keeping in mind that the facilitators were school counselors and school social workers that were trained in the intervention in a 5-day period, about 6 to 7 hours of training on each day. They were trained through role plays, didactic presentations, by watching videos of some of our prior sessions. They were specifically trained in engagement rates and problem-solving barriers to engagement. Engagement here is defined as attendance at one of our first 3 sessions, which is the way that we have traditionally defined engagement. Really also led, some of this engagement work was led by Doug Coatsworth when he was at the Center for Family Studies many years ago. And what we found was that we had approximately 80% or a little less than 80% of our families had attended at least one of the 3 sessions. The mean number of sessions attended across all 370 plus families that were randomized to the intervention arm was about 6.5. And you see there quite a bit of relatively high standard deviation, because again, we did have 20% of the families or so that did not engage in not only the earlier sessions, but in really none of the sessions. Those families that did tend to engage, those families had an average of about 7.8 sessions. In terms of our fidelity ratings, although I did not present it here, our average fidelity rating here was about a 4. And to give you a sense, that is pretty good. Our master trainer and master facilitator, her average fidelity ratings are in the 5s, 5.2, 5.3 range. So a 4, 4.1 range was really pretty good for these school counselors and these school social workers. In terms of the results for this study, I won't go through them all. Again, all of these findings that I'm presenting here today have been published mostly by trainees of mine, either doctoral students or postdocs or early career staff, which is one of the things that I'm very proud of, and like to give opportunities to my early career scholars and trainees. So Yanine in this particular paper found that using a 2-part growth curve, we did have a significant effect, not only in terms of drug use, particularly in the drug use frequency part, not in the binary part of whether they used or not, but specifically for those youth that reported using, the frequency of use what was significant. We had also positive similar findings with youth who reported a condom, or in this case, sex without a condom, favoring the intervention arm relative to prevention as usual or standard of care. We had similar effects on some of our family functioning indicators, where we did see really the same type of trends that we see in a lot of our studies, not all, but in a lot of our studies, where we do have immediate improvements in family functioning from baseline to 6 months post-baseline, then see really a flattening of the curve, and then having those changes really having an impact in the outcomes at later points in time. So really consistent with the prevention literature, that the effects of family-based interventions on behavioral outcomes are really somewhat delayed and really are not observed until a year and a half, 2 years, or even further out. Really speaking to to the importance of following up these families over a longer period of time, so that we do have an opportunity not only to observe effects and some of the outcomes that we propose, but also, as in the family checkup and other interventions where they have observed significant changes in outcomes that were specifically not targeted by the intervention, such as obesity-related outcomes, such as BMI, where really some of the interventions, such as the family checkup, have seen some of these effects longer term. We have observed some of the same effects across a number of different outcomes, specifically across internalizing symptoms and suicide, as you'll see in the next couple of slides. And we have over and over again seen some of these crossover effects. There's a series of papers that Tatiana Perino and Annalie Brinks and Hendricks Brown and George Howe have participated in on looking at the crossover effects of some of our interventions and other outcomes, including, as I mentioned earlier, internalizing symptoms. Here is one of these findings. A more recent finding is in the most recent special issue of Prevention Science, where Tatiana, Annalie, and George and Hendricks published a paper replicating some of these findings in a larger trial. And basically what we have here is that the intervention condition, Familia Sunitas, had an impact on trajectories of internalizing symptoms, but only for those cases that reported low levels of baseline communication. And we saw the mediation effect only for those youth who reported low levels of baseline communication. So this is a really nice moderated, mediated model where we do see these crossover effects of the intervention for a particular subgroup of the population. We saw very similar findings. One of my students, Denise Vidot, found similar findings, crossover effects for suicide, and where she showed that youth that were randomized to the community practice, this is again in our effectiveness, using our effectiveness study data, were 110% more likely to report suicide ideation and almost 200% times more likely to report an attempt than youth in the Familia Sunitas intervention. But again, this is for youth who specifically reported low levels of communication. So again, this is in the special issue that Eve Ryder and others from NIDA guest edited in Suicide, Life, and Threatening Behaviors. Over the past, as I mentioned earlier, our focus has turned somewhat to doing some work in obesity. We completed this trial a couple of years ago, an adaptation of Familia Sunitas for obesity prevention, or for health and wellness, as we called it. We're currently preparing our next grant in this particular area of research. This is a colleague of mine, Sarah Messiah, and I teamed up on this one. This is one of these really great examples of two of individuals with complementary expertise. Sarah actually and I were PhD students together, and we went our separate paths. And many years later, we came together. She had expertise in doing prospective cohort studies, longitudinal studies, looking at different risk and protective factors for adolescents who were overweight and obese. And I continued to do intervention trials, again, mostly in the area of substance abuse and sexual risk behavior. So we came together to put in this grant to NIMHD that was funded to adapt the Familia Sunitas intervention and to really focus it on health and wellness. So with that said, we had two aims in this particular study. The first, as you see here, was to examine the efficacy of Familia Sunitas extended to target obesity relative to the control group, which was a standard of care, and increasing both physical activity and improving quality diet among Hispanic youth who were overweight and obese and their parents. So we were focusing on not only on the Hispanic youth, but also on their parents. The second aim was to look at secondary outcomes, including but not limited to BMI and blood pressure among these Hispanic youth and their parents. Although it wasn't listed here as an aim, we also focused on whether the Familia Sunitas for health and wellness intervention would increase the family function, the same family functioning indicators that I had mentioned in the past, specifically communication, parental monitoring, family support, and parental involvement. As with all of the intervention work that we do and all of the formative work that we do, we really do an iterative process to inform the development of our interventions. There was no exception here in this particular study. First, I'll point out that we really did have a multidisciplinary teams. Not only did we have the team that was responsible for the development of the Familia Sunitas intervention, but as I mentioned, we had someone who I had teamed up with who had done a lot of work in the area of obesity prevention, granted in really longitudinal studies. And then we teamed up with an exercise physiologist, a licensed dietitian, and staff from the Miami-Dade County Parks and Recreation System that really provided important feedback on this particular study. We also, of course, solicited important feedback from adolescents and parents in the general community. How was the intervention developed? And again, I won't go through all of the details. This paper is led by, again, one of my trainees, Sarah St. George, and she shows that we initially did some focus groups with 20 families. Then we piloted the prototypes of the intervention sessions with an additional 19 families. Then we obtained feedback from the park staff and from other experts. And then we launched our pilot and subsequently to that, our efficacy study. A breakdown of what the session by session content looks like. You will certainly see a significant number of similarities between the session by session content of the adaptation versus the original intervention. What you see in terms of similarities is the number of group sessions is the same. So we have 8 group sessions, and the family functioning indicators or constructs that are targeted in the group sessions and in the family sessions are the same. So again, family communication, behavior management, parental monitoring of peers, etc. You'll also see that we kept our 4 family sessions. Things that changed that were not consistent with our original intervention was all of the youth and the parents and the coaches said that they wanted activities that the kids could, physical activities that the kids could do together with just themselves. And so we took the SPARK. For those of you who are familiar with evidence-based physical activity intervention, SPARK is one of those interventions. And then consistent with the fact that this was, again, a model where we believe that the parent is the change agent for the family, is that we did have activities, both physical activity interventions and some diet modules or diet interventions where the parents and the youth participated in those sessions together. So this was very new. This was a lot of session content that was added to the intervention. We did not increase the content of the sessions. So this was, it did not go from a 2-hour to a 4-hour session. What we did was that we trimmed down all of the content that was specific to substance use, sexual risk behaviors, cigarette use, and alcohol use. And we really, by removing a lot of that content, although we did keep some, we were able to add some of this new obesity-related outcome. Essentially, in a snapshot, this is what our study design looked like. We approached almost 800 families. We successfully assessed and randomized 280, you'll see there, and even split between the intervention arm and our standard of care control group. We assessed families for baseline 6 and 12 and 24 months, a slightly shorter follow-up than the 2.5 years or even 3 years that we have done in some of our prior studies. But because a lot of the formative work had to be done in this particular study and some of the pilot and feasibility testing, we really did not have sufficient time to be able to follow up families for a 3-year period of time. In terms of the participant characteristics, very similar to some of our other studies. One important part here is that the adolescents, as I mentioned earlier, had to be overweight or obese. You see, again, very consistent characteristics and demographics with respect to the parents. Not much different than in our other studies. What did we see here? Very consistent with our other studies. We did find improvements, from baseline to my apologies. We did see improvements from baseline to post-intervention or slightly post-intervention or a 6-month follow-up with respect to a lot of the family functioning indicators. Again, very consistent with what we've seen in our past studies. What was not consistent, and perhaps certainly for me, a little disappointing, is that we did not find significant intervention effects on our adolescent outcomes. This included the BMI outcomes, the physical activity, the diet outcomes, and so we were a little disappointed that we did not observe significant findings for the youth. However, we did see some significant findings for the parents. In fact, we saw significant findings on our primary outcome for diet, which was added sugar added. We also saw significant findings on fruit and vegetable intake and whole grain intake. We also did see, we collected some biomarkers and some anthropometric data. And so we did see changes in specifically reductions in the parents' BMI. Again, unfortunately, those did not extend to the parents. We certainly ask ourselves, why did we not see that? We have a number of theories and hypotheses. One of them potentially is that, we did not follow up these families. Perhaps the changes in the parents' behaviors would have led to subsequent changes in the youth behaviors. Perhaps also was that, unlike in substance abuse and sexual risk, we're really, once we see some changes, they're sustained long-term, perhaps the intensity in this particular study for obesity prevention has to be much more intensive. And in fact, there are some meta-analysis and some reviews that really do suggest that interventions for obesity prevention, for them to be efficacious and or effective, they really have to have a greater dosage than what we had here. So again, no real conclusions, but certainly some hypotheses. One of the things before I start speaking about our online and e-health intervention, I'd like to point out that even though we significantly reduced the content of the substance abuse, the sexual risk behavior content, my former postdoc, Alejandra Fernandez, showed in a paper she published in Prevention Science that the intervention still did have an impact on some of those outcomes, in fact, on most of those outcomes, irrespective of this, and despite the fact that we removed a lot of that content. So really speaking about the importance of the mechanisms of action that we do target, and that improvements of these family functioning indicators, whether or not we cover content specific to a specific behavioral disorder, we are likely to still show changes and improvements in those behavioral disorders if we do have changes in the mechanisms of action. So about 7 or 8 years ago, one of the junior staff on my team and I, we started speaking about really the importance of focusing on not only efficacy. We had a lot of work, a lot of really pretty good results with our group intervention work in terms of the efficacy. Unfortunately, as all of you know, the impact or the reach rather of these evidence-based face-to-face interventions is to some extent limited. So what we really wanted to begin to focus on was on maximizing reach while continue to maximize efficacy. And so that about maybe 8 years ago or so now really led us to begin to think about adapting Familia Sunitas for online delivery through mobile phones, tablets, PCs, etc. And so we embarked on a intervention development study. This one in particular was led by one of my early career trainees with some CDC funding, where she spent the latter part of 3 years really developing the intervention and evaluating the intervention in a preliminary efficacy study. And so what I hope to do is to show you a little bit about the intervention and some of the results. So the goal of the online intervention was, one, to really retain the core ingredients of the intervention, really to focus on improving and targeting first and foremost the family world, but also the peer and the school world. Two, to really retain the participatory nature of the intervention. I think one of the hallmarks and one of the important aspects of the intervention, that it is very participatory in nature. The parents participating in the groups are really the individuals that drive the discussions in the group. And so we really wanted to maintain that core central tenet of the intervention. We also wanted to be very intentional about entertaining our families and engaging our families in a very culturally syntonic way. And so because we were going to be translating a lot of this intervention into videos, we wanted these videos to be as culturally syntonic, as interactive as we possibly could make them. Additionally, we also wanted to do even better with respect to increasing intervention attendance. As you saw from our effectiveness study, about 6.5 was our average session completion out of the 12 sessions, and we had about 75+% of our families engaged. So we really wanted to focus on improving that a little bit. Having said that, there is a significant literature in the e-health world that really shows that, in fact, attendance and retention rates in some of these videos is really not any higher. In fact, in a lot of cases, it's lower when you translate a face-to-face intervention into online delivery. And then, of course, as I mentioned in the prior slide, we really wanted to focus on scaling up the intervention. And actually, I would also argue that we wanted to focus on scaling out the intervention to other populations, to other contexts and other settings. Much like we did for our health and wellness study, this was really an iterative process of intervention development and mapping. We spent, as I said, a lot of time, many of us, a group of 4 or 5 of us, led by Janine, spent a lot of time developing scripts for the intervention, really producing those scripts with the help of our School of Communication here at the University of Miami. We got a lot of feedback from different community key stakeholders on some of those initial prototypes. And then we packaged everything together. And one of the things that we also wanted to make sure, which we were very successful, is to ensure that every element of the intervention, all of the core topics were covered in the e-health intervention. And in fact, when we had independent raters rate and watch our videos, we had 95% adherence to the different intervention, the face-to-face intervention components mapping onto the online one. So very briefly, because I do want to show you a video, what does the e-health Familia Sunitas intervention look like? So first, I want to speak about the 8 parent group sessions. So how did we take those 8 family group sessions and turn them into 8 videos? So the videos, which are about maybe 20, 25 minutes in duration, as it varies a little bit from video to video, consist of 3 components. The first component is a telenovela or soap opera series. So for those of you, who have done some work in this area or familiar with the population, Hispanic parents love a great telenovela, and we wanted to be very culturally syntonic with it. We wanted the telenovelas to be everything you would want a telenovela to be. We wanted it to be dramatic. We wanted each episode to end with a cliffhanger. We wanted it to be, to have a really climatic theme at the, in every episode. We really, again, wanted it to be all of the things that parents would want to see in a telenovela, so that 1, we could engage the parents, but 2, that we could retain the parents and have them continue watching the session. And you'll see a video of that very shortly. The second part of this 20 to 25 minute video, which is this component right here towards the bottom left of my screen, we did like a talk show. So the telenovelas, and I should say that each of the 8 telenovela episodes mapped on to each of the 8 topics of the intervention. So if you recall, the session by session overview, which focused on topics such as communication, parental monitoring of peers, parent involvement in the school world, peer pressure and substance use. Each of the 8 telenovela episodes mapped onto one of those 8 different topics. The talk show host and the families that, or the actors that you see here in the bottom screen. This person here is my clinical trainer and master supervisor. So she's what I like to call our Oprah Winfrey. So every team has their Oprah Winfrey. This is my Oprah Winfrey right here. She was working with a group of Hispanic parents from the community, and all of these parents saw the videos, and after the videos, they processed what they saw in the videos with the facilitator right here. And the facilitator, as this was happening, and each of these talk shows were about 8 to maybe 10 minutes in duration, the facilitator or the talk show host would stop at different points in time and engage with the family at home by looking at the camera and saying, so you, parent at home, what did you think about this video? Tell me, how do you think that this translates to the communication style that you have with your own adolescent? And parents then were encouraged to complete the interactive exercise that would then pop up on their screen, and the facilitator would say, now it's time for you to participate with us. And so I'll give you an example of one of the interactive exercises. One of the interactive exercises said, parents, what are the most important goals for your adolescent in each of the 3 worlds, family, peers, and school? And the families would drag from a long list of goals, would drag it into each of these 3 worlds, or would type in their own goals. And what did we do with those goals that the parents completed during that interactive exercises and other interactive exercises? During the virtual family sessions, so these family sessions are now the 4 family sessions that we did live, so that the parents could practice the skills that they had learned in the group sessions with their own youth. The parents, and this is sort of what you see here on the right-hand side with the mom and the adolescent. These, about 80 years ago, started doing these through really video conference software, much like telehealth or telemedicine. In fact, much like what we've been doing for the past 2 years, we started doing this, as I said, about 80 years ago or so. And It's a live session, but both the parent and the child are communicating with their facilitator online remotely. So that's how we replaced the group sessions into these videos, and the live family sessions are still live, but are now done virtually. So let me give you a sense of what the telenovela looks like. And I'm going to turn on the video here. Not the video, I think there's a way here. Let's see, I did this yesterday. Okay, and of course I can't find it here today. Oh, here it is, share sound. Okay, great. So what you're gonna see here is 2 minutes of the telenovela, and then I'll pause it, but just to give you a flavor of what we did here.
Hey, ¿qué haces en el sofá? ¿Tu hermano?
En el cuarto, tenía dolor de cabeza y yo no me quería acostar. ¿Cómo está tu jefa?
Mejor que yo. Es una melodramática. No se rompió nada. Debería actuar en novelas. Bueno, hasta mañana.
Wait, Mommy. I lied about Darwin.
Gabriela, please. Español.
Tenemos que hablar.
Tú siempre escoges los peores momentos.
No lo escojo. Son los únicos chances que tengo. Siempre estás corriendo o cansada.
Bueno, está bien, dime, ¿qué te pasa?
No es mí, es Darwin. Parece que...
Gabriela, perdón, hija, pero de verdad estoy muerta. Mañana tengo que llevar a doña Silvia al radiólogo súper temprano. Hablamos en otra ocasión, ¿ok?
Yeah, sure. En otro momento.
Okay, so you're interested in learning what happened? That's for next presentation, folks. Okay, so I hope you get a sense that every episode ends with a little cliffhanger. Again, the goal is to really get the parent to come back. So in our efficacy study of this intervention, we randomized 230 Hispanic youth into one of these two arms. You see, again, very short follow-up here, particularly for this one. Really post-intervention assessment and 9-month post-intervention assessments here. In terms of, here's, I think, one of our more interesting findings. And I think we certainly achieved our goal. So keeping in mind with what we have seen before, about 6.5 sessions attended across all of our participants, now our average session attendance was almost 9 across the 12 sessions, so significantly higher attendance. Where we saw the much higher attendance was in our parent group sessions, where before we had about 3.5, on average about parents attended about 3.5 of our group sessions. Here it's almost 6 of the 8. So really, really significant improvements in our in the number of sessions, particularly in the group sessions. And what we attribute this to, and in fact, what we saw in this particular study was that about 40%, we had 90% of the families see all 8 sessions. So we only had 10% of the families that didn't see anything at all. And more importantly, what we saw, which was very interesting to us, about half, I think it was like 43, 44%. So just shy of half of our families binge watch the sessions. And so much like some of us, certainly I'll speak for myself, when there's a great Netflix show, I tend to watch multiple sessions in a given evening. So we were we were tracking when parents were watching this and how often. And what we did find was that there was quite a bit of binge watching. Some of our outcome findings here, I won't go through them all, but we did have significant effects. We did not have a significant effect on condomless sex here. One of the reasons why we attribute that to be the case, again, going back here, we had a much shorter follow-up. We had 9 months post-intervention. In our other studies, we had 30 and 36 months post-intervention. Our kids were just shy of 14 years of age for this study. So even 12 months out, they were, not quite 15. So many of them had not been engaging in condom use. And in fact, that percentage was less than 10%, if memory serves me correctly. I also mentioned earlier in terms of, we not only wanted to scale out we wanted not only to scale up, but we also wanted to scale out. And so we have an effectiveness study that we're completing. Actually, we're at collecting some of our 36-month post data right now. And this is working in primary care settings in South Florida. Again, a lot of formative work for us to really begin to think about how would we integrate the intervention into primary care. This is a paper that one of my former Ph.D. students led, where she did focus groups not only with parents, but also with clinic staff and physicians working in a number of different clinics in the Miami-Dade County area. We did a small pilot study where we worked with approximately 20 families. And again, we found this to be found a lot of success. Almost 90% of the families watched a lot of the sessions, which was fairly consistent with what we had seen in our efficacy study. In terms of scaling, I also mentioned scaling up. We've done some work in a number of different places, not only here in the US. The intervention is being implemented in a number of communities across numerous states. One of those states actually is Pennsylvania. We've been working in Chester County now probably for about 7-8 years, maybe a little bit more, plus or minus a little bit. We've also been doing some work in Latin America, Ecuador. Some of our most exciting work is in Chile, and I'll speak a little bit about that work here on the slide. So in Chile, we've been doing some great dissemination work in collaboration with the foundation in Chile and with the federal government. So the federal government, probably about 4 years ago or so now, they launched through the Secretary of Health, and specifically the Assistant Secretary of Delinquency and Prevention within the Chilean federal government. They launched a program called Sistemas Lazos, which is a system of programs. It translates roughly into a system of programs where the Chilean government chose 3 interventions: a universal preventive intervention, a selected intervention, and an indicated family therapy intervention to disseminate across the country. So we started working with them probably about 7, maybe 8 years ago or so now, and we started implementing the Familia Sunitas intervention in two communities when we first started. That has grown substantially over the years. We're in 20 communities now and hoping to expand to double that beginning January, with really the long-term goal, to really span the entire country of Chile from south to north. In terms of, and I'm coming down to my last 3 or 4 slides here, in terms of some future, actually maybe not so future, because some of these are more ongoing and current work, but additional current and future work that we've been thinking about. This is a former trainee of mine who was very interested in working with me. I had never worked with sexual minority youth in the past, but he was interested in beginning to work in this area. And so I really followed his lead, and we worked together to do work on an F-31 that he was funded to do, and actually more recently a K award. And some of the early work really started looking at the prevalence rates of substance use, sexual risk behaviors, and internalizing symptoms among Hispanic sexual minority youth relative to their non-Hispanic sexual minority youth counterparts. And we found significant differences between sexual minority youth and non-Hispanic sexual minority youth, not only in terms of substance use and risky sex, but also in many of internalizing and externalizing behavior problems. And Manny has published, both of these papers in Journal of LGBT and Journal of Adolescent Health. Some of that work that my former trainee did is currently being picked up by my current PhD student, who has continued to evolve this work with the help of my staff and myself. We have spent probably the latter part of maybe actually a little bit more than about 2 years, maybe a little bit more than 2 years, on really setting the stage to inform the development of a new intervention. And so as all of our work is iterative and really we do a lot of formative work, we conducted an initial set of focus groups with parent youth dyads, and we found a number of themes that emerged. And you see some of those here on the screen, such as really conceptualizing the disclosure and the acceptance process for both parents and youth. Here were some of the themes that came out from the second stage of our formative work. The need, as youth specifically express, the need for sexual health content on both parents and youth, the need for a support system and having really enriched relationships and communication, and also specifically for parents, really a need to really understand, LGBTQ health, really understand even terminologies that they were not familiar with until their youth disclosed, their specific orientation to them. Here, this is, again, another paper that my student just got accepted actually about 2 weeks ago or so at Culture, Diversity, and Ethnic Minority Psychology, where it basically shows some of the steps that we followed to develop the intervention. From a phase 1 to an additional interviews of 24 parent youth dyads, with then sort of phase 2 after the intervention was developed, Familias con Orgullo, or Families with Pride. We did a pilot study with 12 families. We sought feedback from those 12 families. And then we did the modified intervention with an additional 18 families. We completed the pilot study, and here you see some of the work. And again, we certainly were not powered to see significant effects, but we did see promising effect sizes in the vast majority of the areas that we were focusing on, including our family functioning indicators like before, positive parenting and communication, but also some of our behavioral and emotional disorder outcomes, such as depressive symptomatology as measured here by the CESTI. One of the outcomes where really we did not see any type of movement in was in condom use. Again, here our study design was baseline and post-intervention effects. These kids were young. They were on average about 13 and a half, 14 years of age. And so very, very, very small number had begun to engage in sex, period, and even fewer engaging in risky sex. So we really do believe that the youngness of the sample and the fact that we didn't follow them up, may have contributed to the lack of effect sizes for condomless sex. So I am at my last slide here. This is some current work that actually Hendrix Brown and I are just starting right now. This is an NIMH trial that we're now in, I guess, in month 3 or so. And this is a type 1 effectiveness implementation trial where we have made some enhancements to our current intervention to also focus on mental health promotion, specifically on the reduction of depressive symptoms and reductions in suicide ideation and behavior. But as I mentioned earlier at the very, very, very beginning of my presentation, the focus on this particular study, the primary focus on this particular study, is looking to see whether the 18 clinics, so here you see how we're going to randomize. So we're going to randomize a total of 18 sites. into cohorts of 5 as to when the intervention is going to be rolled out at these specific clinics. So as you can see, each of these sites will serve as their own control, and really with a focus on sustainment of the intervention in these clinical settings. So which is really where the type 1 implementation here sort of takes place. We were also, Hendricks and I, and Jose Shapusnik and others, and Greg Ahrens and many others, have a type 2 effectiveness implementation study currently under review, where we're focusing not only on measuring the effectiveness of Familia Sunitas in primary care, but really consistent with a type 2 study, really focusing on testing the implementation strategy first, and then the intervention, which is what we're hoping to do in that particular study. So with that said, I think I'm literally about 5 minutes over, but hopefully I think we still have 20 plus minutes for questions. I'd like to just end by thanking all of the agencies that have supported this work over the years. At NIH, NIDA, NIMHD, NIMH, and NIAAA. Certainly some of the intervention development work that has been supported by CDC. Also, this couldn't be done with all of the families and our community partners that are always so willing, to give us a hand and to really, give us and provide us with their wisdom and their valuable feedback. And last but not least, I want to really acknowledge my research team, who I'm very fortunate that my research team members have been with me for 10 years or more, and some actually started when I started. So I'm very grateful to all of them. It takes a village, and to all the trainees that have participated in this program over the years. So with that said, I know I spoke a lot, but now we're in 5 minutes or so. So I hope I kept you somewhat engaged. And again, thank you so very much for giving me this great honor and opportunity.
Oh, thank you so much, Willie. That was incredible. It's a lot to take in. What I think I'd like to do is open it up for questions. And if I am correct about the technology, if you click to raise your hand, I should be able to see that and grant you permission to just ask your question. And that way it can come directly from you. There were, Sarah, you posted a couple of questions during the talk. They were a little bit tricky to interject, but if you'd like to chime in now, I'd be happy to have you do so. Okay. I see there are 2 hands. Sarah, we'll let you go first then.
Okay, sure. Well, yeah, thanks, Willie. That was really, really great. And yeah, I had a few kind of smaller questions and then one big question. I guess I'm going to start with the big question. So sorry about that. So I've been thinking a lot about culturally specific family interventions versus family interventions that include a more diverse racial and ethnic population in their materials. And so the trials of the Strengthening Families program 10 to 14, so those had a higher dropout rate when the materials were revised to be more racially and ethnically inclusive. But it seems that the original curriculum, which was more focused on a white population, white and rural, right? And the Strong African American Families program and Familia Sunitas, which are all much more racially and ethnically and culturally specific, they seem to have lower dropout rates and good, consistent positive effects. So I was just wondering what you thought about that.
Yeah, it's a good question, Sarah. And as you said, it's a complicated one to answer. Certainly, I know some of the work that Felipe, Castro and, some of his colleagues have done, where he's tackled the same exact question that you answered. And a lot of his work has concluded that, as you may know, that, there is evidence that culturally syntonic or culturally appropriate interventions tend to do better than those that do not. In our work, every time we've done formative work, whether it be for, our Hispanic sexual minority intervention, or whether it was for any of the more recent adaptations of the Familia Sunitas intervention. Culture is always a central theme that comes up in some of the discussions, mostly from the parents, but also from the youth. And, it's the vast majority of the time they're not prompted. And some of the things that come up, and I'll give you a couple of examples, is, issues of acculturation come up quite often in some of our formative work, where the parents are always comparing their experience with their youth to what it was like for them in their home country. And, what it was for them when they grew up and what they were allowed or not allowed to do. So for example, a lot of our first generation Hispanic parents that we work with, find that, their adolescents spending, a night at their friend's house. I mean, it's completely absurd and unacceptable and deviant, right? How could they even think about that they want to sleep somewhere else? And so, one of the things that we do in the intervention is really attempt to normalize that, in the context of this is the acculturation process. And so things like that always, I think, come up. And I think that because of this is the fact that, we do see, these effects, over time and over trials, because we integrate culture into a lot of our sessions. Even in our more recent work with with Hispanic sexual minority youth, I tell you, this has been in 20 years, 17, 18 years I've been doing this type of work. I think some of the most interesting group sessions I have ever seen. We video record all of our sessions to do independent ratings of Fidelity. And, in the first couple of sessions, it was really interesting, how prominent culture was in this particular intervention, specifically for the dad, because we had not many, but we did have 3 or 4 dads, out of the 20 or so that participated in the intervention. And, and dad, even from the first session, when, one of our first activities is that everybody goes around to sort of introduce themselves, et cetera. A couple of our dads said, I'm so-and-so, and I'm here because my youth has a problem, right? Quote unquote, a problem. And I don't understand, how my son can be gay because I'm looking at him and he acts like a man, and in the Hispanic, and then sort of talking about, the culture. So I think that in our work, certainly, I think, we've shown that culture has been very, very, very prominent. In fact, I'll just give you one more thing, Sarah. I know you have other questions, and there's other questions, I'm sure. But in some of our earlier work, this is when I was a graduate student, I wasn't very involved. We had studies of other interventions that when we attempted, or others, I should say, attempted to adapt one of the Center for Family Studies other interventions for other populations, for other ethnically diverse populations, specifically for African Americans, we did not have very good results for that particular intervention study. And so that work sort of really was never pursued. So anyway, I know this was sort of a long-winded answer to a very complex question. So I hope I didn't talk too much here.
Yeah, no, that's great. It's just really interesting to think about what that means for just family interventions in different kinds of communities. And yeah, anyway, thank you.
Thank you, Sarah.
All right, next we have Brittany Rhodes Cooper.
Hi there. Hi, Willy.
Hey, Brittany.
Thanks for the great talk. I was really struck by the interesting different findings you had with families or youth who reported lower levels of quality communication with their family at baseline. So with the one, you found iatrogenic effects of that health promotion intervention that didn't have an explicit focus on family functioning or enhancing family functioning. And then in comparison for the Family Unitas program, you found enhanced effects for that particular group, also similarly who had lower levels of baseline family communication. So I was just really struck by that kind of not dichotomy. It makes a lot of sense to me, but I was just wondering if you could talk a little bit more about the implications of those two findings together, what that means for our approaches to universal interventions, but also maybe more indicated interventions that are focused on families who might already be struggling with communication with their youth.
Yeah, thank you, Brittany. And I think that's certainly a great observation, a great point. And I would say that there's a real, I think in terms of implications, targeting family-based interventions for those youth who are indicated, right? And now I'm defining indicated as low family functioning or low communication. It's where we've seen most of our effects, or consistently across the studies that I've done with this work, or George Howe has done, or Hendricks and Tatiana and that group have done. It's been a very, very consistent pattern, which really speaks to the fact that these family-based interventions, in my opinion, have a lot of impact for families who have low communication, when the target of the intervention is really focused on improving general family processes, improving general communication. I think less so, and in fact, perhaps iatrogenic effects, when the focus is on improving communication around a certain topic or a specific area, when the general communication isn't strong, when that foundation isn't there. So I think what I would say, it's important to improve general communication skills first, with those families that are most at risk, but don't attempt to improve communication skills around a specific theme or a specific content area unless that foundation is built first or is established first.
Great. Yeah, that makes a lot of sense. Thank you.
Thank you, Brittany.
Great questions. I don't see any other hands raised, so Mark Greenberg.
Oh, I see Mark. Okay. Hey, Mark.
Great talk. So great that you're the Bennett lecturer this year. I have a question about your obesity work. You switched to the e-health to create greater reach. Have you done any work on obesity now with the newer e-health model?
Yeah. So no, Mark, and actually that's one of the grants that we're preparing now. I do have a former postdoc, now a colleague, who does have a K award. Her name is Sarah St. George, who has a K award, and she or we are working on developing a very brief digital parenting training program for Hispanic families and youth, particularly for families that report poor quality diet and poor physical activity. And that work is sort of formative right now. She is just starting her feasibility pilot test. And I think in the next 8, 9, maybe 10 months or so, we'll have some findings on that. But yeah, so keep an eye out for some of her work. She just published a great, really, I would say the most comprehensive meta-analysis review in the obesity field on intervention works, and it has a very big focus on family and parenting training programs. Just published in Obesity Reviews.
Great, thanks.
Thank you, Mark. Good to hear you.
All right. Oh, Sarah.
Sure, I'll ask another question. So I was curious about that sustainability study. And is the grant paying for the intervention delivery when it starts at each of those cohorts? So like that through that green line? And then, okay, so then are you watching and tracking the sustainment of the program just kind of naturally? So like automatic withdrawal of funds and okay, what happens or are
Exactly.
Okay.
That's it. Exactly right.
Okay, and are you doing much to help them figure that out, or is it?
So that's a good question. So we literally are just getting started and building, the relationships and selecting mostly a lot of federally qualified health centers, but not exclusively. And I think we're just asking the questions right now. So I don't, it's not a real active intervention, but we're asking the questions and we're, asking, so how do you think that you can sustain this program over time? And so, the federally qualified, some of our federally qualified health center partners have said, well, based on, what we know of the intervention thus far, we think we can use this billing code, right, to bill for the intervention. So I think we're asking the questions, and they themselves are sort of working on how to do this, but they do know that sustainment is really our primary outcome here.
Yeah, that's true. That one's at those health centers. So it's not an independently functioning kind of community organization doing the live program. Okay, yeah, that's interesting.
Yep. So we'll see, we're, I guess, 2.5 months in of 4+ years. So we'll see. But thank you, Sarah. That's great.
Yeah, great. Thanks.
All right, we have just a few minutes left. Oh, I see Janet Welsh has a question. Go ahead, Janet.
Hey guys, Willy, thank you. I'm speaking to you from my classroom where I had my undergraduates watch your talk. So
fantastic.
as I always do that to them. And you were actually one of the people they could understand. It's kind of hit or miss with the Bennett lecture. So thank you very much for that. But I had a question about your obesity study, and I was curious that that you impacted the parents, but not the kids. So, like, what do you think that was all about?
It's such a great question, Janet. I'm not sure I know the answer, to be very honest with you. What I can say is that my colleague Sarah, actually the one I just mentioned, her dissertation was focused on developing and evaluating a parenting training programs to reduce BMI and improve physical activity among African American youth and their family. So her mentor at her prior institution was working with African American families. And she, when she finished her dissertation and she published her results, she found no significant findings on the youth outcomes, only on the parent outcomes. Her mentor found the exact same findings in her own study. And, I don't know that we know exactly why. I think that, it's so, she and I sort of always compare and contrast how, what are the similarities and differences between parenting programs designed for for substance abuse prevention versus obesity prevention. And, what we come down to is that we wonder if the dosage is sufficient, to observe changes in the youth. Unfortunately, because it's much harder to recruit youth for obesity prevention studies. I have found that in my own work, I've been pretty successful recruiting Hispanic youth. We were able to meet our target for our obesity study, but it took a lot more effort than certainly for our substance use studies.
So,
in particular,
one person who's done something similar to that. A few years ago, I worked with one of Matt Sanders' students on the lifestyle triple P, which is that, right? And we did a little pilot of that here where we modified the menu, the recipe book for American tastes and things like that. And they get kid effects, or they did in a couple of their studies. And we got a pretty similar pattern as well in our little pilot here in Pennsylvania. What do you think's different? I mean, do you think there's a cultural factor there that's interfacing that you're picking up on that we didn't get in our rural Pennsylvania sample? What do you think that interfaces at all with this?
That's interesting, Jenny. So can I ask you a question before I respond? So you found changes in the youth behavior short term?
Youth BMI, yeah.
In the youth BMI, interesting.
Yeah.
Yeah. I'd love to read about that. Yeah, part of me is yes, I mean, we did something very similar to what you did with the menus and sort of coming up, with a, culturally syntonic menu and how to, cook healthier, right? We're not going to get the Hispanics to move away from their rice and beans and certain foods, right, that are culturally very appropriate, but just sort of cooking them healthier. And I think the parents got that. And in fact, we saw changes, but I don't know if it's just they didn't, for whatever reason, they didn't reach the kids.
One thing Matt emphasized in his was there was a big push on screen time, right?
Mhm.
And did you guys have that?
We looked at it and it was part of one of our sessions. But again, it wasn't a focus, certainly.
And why?
And so did you focus on screen time?
Did you have, yeah, we did. We did it exactly the way they did it in Australia, except for the food. We redid the recipe book and used just the My Plate USDA.
Yeah. Mhm.
And it was funny because my staff here, when we're making the cultural adaptation, to go and look at that recipe book and said, because everything they eat in Australia is like all sheep, right?
Mhm.
We don't eat that. And so so that was the only thing we changed. The only other thing we ran into is that program also had like a physical activity book that they gave the parents. And the only part of Matt's thing that we couldn't replicate was that they had the parents role play the activities and play them in the parent sessions. And our parents in Pennsylvania flat out refused to do that. They were embarrassed and they wouldn't do it. So other than that, we just did it the way they did it. But I was wondering, I was curious, and I can't remember what our sample was. So don't ask me because I can't remember. But I saw that yours was overwhelmingly girls. What was that, a recruitment thing?
So it was overwhelmingly the female for on the parents. So the youth were more split down the line.
That was the parents. Okay.
Yeah.
Shannon,
It's interesting, and I would love, and I may pick your brain actually, or send you an email about some of those articles because I'd love to look at them actually as we prepare sort of this, the next phase of this.
Okay.
And thank you.
Sure.
And thank you, and I'm glad your undergraduate students watched and hopefully I kept them up.